keep those introductions coming with your, for those of you who just joined in, with your single words describing how you are. And I guess the thing I would say is pretty awesome. And I am full of thanks that you guys were willing to join us when so many of you are feeling wiped and COVID out and frustrated and exhausted. And I kind of knew that would be the chat. So I just wanted to acknowledge it up front, and yet you're still willing to come together and try to figure things out. So I'm impressed and grateful to be part of this group. So with that, we are going to have some fun because we're changing up the agenda that I sent to you. It all is going to have the same content, but we're going in a different order. And so I would like to start the meeting with Dr. Kate Ackerman. So I think that many of you may not know Kate. I'm going to let her introduce herself, but I just want to say Kate is one of the vice chairs in the Department of Pediatrics. She's an incredible leader, an incredible advocate for kids, and she does amazing work. Her background is in critical care, and she runs the Pediatric Sedation Suite, and she has an incredible team down there. And she's going to talk to us today about the great work that they're doing and offering in partnership with all of you for your patients who have developmental disabilities or chronic health concerns or reasons why they might need some special care and get done some of the things that you might be able to do in your office otherwise, but under the circumstances cannot. So Kate, I'm going to let you take it away, and we'll see if that screen share works.
Okay.
Thank you for joining us tonight. I'm so grateful to you for coming on this call. And
no, this is great.
You know, you've got pretty much a pediatrician or a family physician or a nurse practitioner from every single one of the pediatric and family medicine practices who care for kids within the AHP network across the region on this call.
Well, this is so great because pre-COVID, we had plans to try to get this message out, and I didn't think of this mechanism. So thank you for having me, because I hope, you know, I know COVID is just a crazy pain in the neck and unbelievable. Hopefully I can give you some news that will help you. Hopefully our service can help you with some of your kids. That would be my goal. I did just send the slides, but I can also share. So let me do that possibly. Oh boy. No, I have to open it first.
Uh-oh.
Hold on.
If it looks like it's going to be a pain, Kate, I've got them right here and I can throw it up for you. No problem.
Let me see if this works. Did that work? Is it in the right mode?
Just about. You just want to do your slideshow, and then yeah.
There you go.
Okay, great.
Perfect.
Looks good, Kate.
Oh, hi, Pat.
Hey, Pat. Patrick Brophy's on the call with us too.
How are you? Sorry,
I
I just joining the team. It's been kind of a crazy day.
Yeah, I was just saying that I look forward to sharing what we can offer, because I'm just hoping we can make lives a little bit easier for people, especially when you have patients who have a lot of challenges. So yes, thank you for the introduction, LJ. I come from Peds Critical Care and I direct the Peds Sedation Service. I need to do that. Okay, so my goal here is just to let you know about our service and give you contact information. So if you need help with any of your patients getting any type of procedure, even if it's going to be an operating room procedure, we are happy to help you navigate the system. And as you'll hear, we're happy to help you bundle procedures if you would like that, which is always popular. So our Peds Sedation service is actually really great, really grown. I've only directed it for the last year and a half, but it started maybe 20 years ago. I've been here 12 years. When I started with the service, we were just doing about 2 sedations a day just for the HEMONC service pretty much. And right now we're doing about 100 a week, sometimes more, in 5 different locations of the hospital and for all types of services. And we've had the luxury of being able to expand our services now that we have a new facility. So we have the people doing the sedation, our Peds Critical Care attendings, and then we have 1 nurse practitioner who started last June, and that's Sammy Ferguson, and she is there. Can you see my pointer? And that's the person who will be very helpful to you if you need any help with any of your kids, because she does a lot of our care coordination, and she also does our minimal sedations and our moderate sedations for low risk kids. We also work closely with Child Life, and in our unit we have a main Child Life specialist, and then we work with a lot of the other specialists from other areas of the hospital. And we have nurses who are specially trained to assist with sedation and procedures, and actually with anesthesia as well. Oh, yeah, I think you can see me, although my lighting's bad, but that's me. And this is Dr. Van Der Yat, who has been in this working for URMC for a long time. So a lot of you might know him. He also provides some sedation service as well as all of our critical care attendings. And these are two of our nurses. This is one of our techs who is posing for us. So since we have the new tower, we now have a procedure room, and we never had that before. So this is a picture, some of our staff, but looking, we have a procedural unit. It's actually called the Imaging and Procedural Care Unit. It's on the ground floor of the tower. And if you go into that unit, there's this hallway, and there are 8 pre-post rooms. So that's what you see here, like 3 and 4 and 5. They're about like 12 by 12 rooms with all of the goodies, you know, that we need to take care of a patient in recovery. And then at the end of the hall here, there's quite a large procedure room. So that's what you see here. Really large enough to do a small surgery if we wanted to, and we can do all kinds of things in that room. So what kind of procedures are we covering? Well, this is a list. It's a large list. Some of these might be of interest to you, but I wanted to specifically talk about some of the ones in yellow here. Our GJ tube and our feeding tube kids, and our growing practice of needle phobic kids and kids with behavioral and developmental needs and autism who need, you know, what are normally office procedures like immunizations and blood draw. I'll also just mention MRI and dental as part of our bundled plan. So for our sedation, so in pediatric sedation, we don't like to say conscious sedation, but you see it a lot because some of the other specialties are still using it. It doesn't really make a lot of sense. Nobody really knows what that means. In pediatrics, we are using the terms minimal sedation or anxiolysis, moderate sedation, deep sedation, and general anesthesia. And the reason why that's important is that for every child, we develop a plan and we target a level of sedation, and that target lets us, that target determines what kind of resources we're going to need. So for a deep sedation, the only people providing that would be myself and my other critical care partners. But for the minimal sedation, we would schedule an appointment with our nurse practitioner, having us as backup and supervision, for example. And, you know, some of you know I'm in business school, actually, year 2 of 2. So I'm really interested in decreasing the cost of care and moving, you know, thinking about value-based care. And we've been successful moving kids who were automatically getting booked for like deep sedation or general anesthesia and moving them towards moderate sedation or minimal sedation with a lot of techniques, a lot of non-pharmaceutical techniques, planning, and other non-invasive sedation plans that I'll mention. So that's exciting. So first, one great thing about having a unit where we work is that we have a lot of expertise in procedures that are done all over the hospital, but if it's difficult or a child's coming back multiple times, it's really important that we just do it using every trick that we have. So we have the child life specialists. We always have the family involved. In fact, the family is often in the procedure room with us while we're doing procedures, which is difficult for us, but I think really good for the family in many cases. We use Buzzy. I don't know, you know, Buzzy, LMX, and Sweeties you'll all be familiar with, but this is J-tip lidocaine, and it's an air-injected lidocaine, and it's really phenomenal. It makes a loud pop like an air gun, but it does not hurt. I've done it on myself, and it provides immediate numbness, and it's great for IV starts. We've used it also sometimes for lumbar punctures with some mixed results. We also have a vascular access team. They do PICC lines, but they also do IVs, and their office is on the ground floor so that we kind of have a rule that You know, we don't try an IV more than twice before calling vascular access services. They have ultrasound. But even before that, the nurses have tools to to look at your veins with the light and all of that cool stuff that I never had during my training. So just mention a couple of the things that we're working on. I mentioned GJ tube changes. So if you have a patient with a GJ tube, the difficult thing is that they need to be replaced under fluoroscopy to make sure that that tube's in the right place. So that introduces a lot of issues because the resource of fluoroscopy has to be lined up with the patient's schedule and needs, and that has to be lined up with services for sedation or anesthesia if they require it. A lot of these kids often have complex medical issues and need other procedures. So our team's collaborating with peds anesthesia and with interventional radiology, and we actually now keep a file. We keep things in e-record, but we also keep actually a protected spreadsheet, HIPAA compliant protected spreadsheet where we track all of these kids. We actually track what did they need to get through their G-tube change and why, because at many centers they rarely need to do sedation or anesthesia for a G-tube, for a GJ change. But at our center, we kind of have everything going on. And so we took a look at that and really, instead of the family and the team saying, hey, you got this with anesthesia last time, we're booking it with anesthesia again, we've been really trying to assess so that we can wean them off to a safer and more cost-effective level of sedation, and we've successfully weaned a lot of these kids. It's really a full team effort, but the biggest advantage is that if the GJ tube fails and they have to come and if they're dependent on it and they need to come, it can be much more easily done if all of these services don't have to get lined up, especially on a weekend. So that's the number one thing. And then also for these kids and others, we like to try to bundle these procedures. So this list of procedures, these are the common ones that we would bundle, and we don't mind at all getting a list from you. We've done this. Sometimes we get lists from the pediatricians that they have, for example, a child with trisomy 21 who needs like 5 of these things. And, you know, we can let you know which things can be done together. And if it's a child who probably needs general anesthetic with an airway to get those things done, the anesthesia team can use our procedure room. So we can coordinate. Our goal is to not have you shopping around to figure out how to get everything done, but to kind of give the burden to us, which I say that now and we're running around like crazy every day doing this. So, but it's all good because we feel like we're doing a good service. I will mention COVID testing. So, you know, New York State put out this thing about COVID testing pre-procedure, and it is required nasopharyngeal testing for anesthesia because they get into situations where they might be doing aerosolizing procedures like bag mask ventilation. For sedation, we really don't, like, we keep the kids spontaneously breathing. So we've been a little bit more flexible about COVID testing, especially for kids for whom that would be a huge burden. And sometimes if it's a child who's scheduled to be admitted to the hospital or they need the testing for another reason, we'll also get that while they're under sedation. But we're trying not to ever do a sedation to do the testing, which actually has come up as well in these crazy times. We have a growing need, or we're seeing more kids being referred for needle phobia, even teenagers who are otherwise normal but have some anxiety and just won't get immunizations or blood draw. So I welcome input, or, you know, we'd love to help you with those kinds of kids. What happens is we usually get a referral, which is basically just an email or letting me know if you know how to reach me, or if you're in our system, an Epic chat, and that can come to me or our nurse practitioner, Sammy Ferguson, preferably Sammy, because I'm always a little busy, but we will get back to you usually within 24 hours, 48 hours. If we don't, feel free to keep bugging us, but we usually do. What Sammy does is screens the patient and gathers the information. Obviously easier if we have records in our system, and much easier if we have an anesthetic record or a sedation record, but we usually don't. And then Sammy will discuss it with me, and we will make a plan and an alternative plan. And then Sammy usually talks to the family and to the referring provider to relay that plan. And then we set expectations and prepare the team for what we're going to do. And we also set expectations for how much we'd be able to do before we can stop. And I'll just give you a glimpse at a typical plan in a second here. But unfortunately, our limitation, we just had one of these, right, is with kids with very high body mass index. There's an, we could get somebody like that sedated and then have airway issues and have no vascular access. So we're hesitant. That said, we do have a number of kids in this category, and we know they do fine. So if we do have records on them, we know they've done fine. If much of their body mass is distributed around their abdomen and not in the head and neck, sometimes they do a lot better. So we can kind of do a judgment call on that. Aggressive behavior in a large child, we're not currently, staffed for or prepared for. We've done it occasionally, again, in a child where we have a pretty good idea what's going to happen. But if we don't, and if other attempts have failed, and if we're not sure, for example, how the child might do with it, we need cranial, facial, or airway issues and active respiratory infections. So if we have somebody who needs a pretty minor procedure or a painless procedure that could take a long time, our strategy is first to offer oral midazolam, even as long as they haven't had any history of a bad reaction to that. And we found that we offer 0.5 mg per kilo up to 15 to 20 milligrams, which is quite high. And we do that 20 to 30 minutes prior to the procedure. We have kids where they've tried Ativan in the outpatient setting and it didn't work. And we try oral midaz at our doses and it works great. So I wouldn't take that as a reason to, think that it might not work. If it's not enough, we will actually add intranasal dexmedetomidine, which as an alpha agonist induces a natural sleep. The book dose when it first, well, it's not FDA approved like much of what we do, but people used to do 1 to 2 mics per kilo. Now we're 3 to 4, but we find, we'll have a child, even a teenager with autism or whatever, they're groggy, but it's not enough to do a blood draw. And they're just kind of, every time you try to get near them, they get agitated. We add the intranasal dexmedetomidine and out asleep for 45 minutes, just asleep. And it's been beautiful. Like we've seen amazing success with it. If it's a painful procedure and we don't have IV access, we can add intranasal ketamine, which is also kind of a new thing. It's not great because the dosing is a little bit iffy and it doesn't work as well as you would like, but it does work. And of course, if we need to, for pain control, we'll use intranasal fentanyl. And then instead of oral midaz, we occasionally use intranasal. We we use that when we need it to work faster and we don't have time, but it's not preferred because it really stings. And we try to make sure that the patient has a really good experience because we know one bad experience will backfire for a long time. And so if we can avoid anything that stings, that's good. And in the future, we will have nitrous oxide. And I think that will be really valuable, especially for the teenagers who have needle phobia and need help having phlebotomy or other things. And then just one other new thing, I just mentioned the sort of non-invasive sedation. Right now, if you have a patient needing an MRI, there's basically two ways to go: no sedation or anesthesia, or general anesthesia. And we know that at a lot of centers, they've had success using sedation for a large population of MRI patients. And so we're actually going to trial, sort of as a QI program, giving MRI, a specific cohort of MRI patients that meet certain criteria, oral Medaz, intranasal Dex, and then we expect, based on the literature and based on our experience using these meds for other procedures, to have, a 90 to 95% success rate. And I think that's good, because then the patient never needs an IV. Obviously, if they need it for contrast, that's a different story, but many of the MRIs don't. And it's a safer sedation, and it's much lower intensity for use of resources. In fact, in some hospitals, who have high volume, just are able to get through a lot of scans without using a lot of resources by doing this technique. So we have a patient tomorrow, our first one. So we can't wait for that. And maybe it's one of your patients, I don't know. They have a headache. And a little bit about the nitrous oxide. So we're excited to get this. This is something also that other children's hospitals have added to sedation services. This is a picture of a portable unit. We're going to start offering it just in our procedure room, but eventually it would be nice to offer it portably to different areas that need it. The system uses a face mask, so that will be one limitation, that children need to learn how to be able to use the face mask. They can help hold it on, just like a dental nitrous oxide. If that's the only thing that we're using, they'll be awake. So actually, child life is critically important, more important than any of the physicians, for this whole thing to be successful. We think it'll be great. We have cases where we have to go to IM ketamine, and we're hoping this replaces that, and also gives us something extra to offer for difficult IV placement, and also for our burn and wound care patients. So I think that's on order now. So hopefully it'll be running in the next 3 or 4 months. And then last slide, I just want to talk about technology and innovation, one of my loves. We really want to move the service forward, and really with an eye on not needing as many, pharmacologic interventions for kids if we can help it. So we're working with the UR Health Lab. It's a data science and innovation group. They're really moving forward with virtual reality. Actually, many of you may have heard about it, but using it for outpatient mental health care and other things. And we've partnered also with Stanford. They have a Chariot program, childhood anxiety reduction through innovation and technology. They led us to realize that how great this projector is. This is a picture of a Nebula Capsule Max, which is available on Amazon for $480. And it's actually been our life-saving thing recently on the service. This picture below shows that it can project at any angle and any size. It auto-focuses on anything, and it's a smart TV. So we just took it to the hospital Wi-Fi. In fact, the one we're using is just my personal one, but we're hoping to get a couple soon. And, a few weeks ago, we had a teenager with wounds on her legs, and she could not look at the wounds. And I think, this is something that could happen in the office too, that, you're working on a body part and they just can't look at it, or they need distraction that's above and beyond a phone or an iPad. Well, we just got a sheet from the drawer and hung it up right, at her waistline, and shine the projector on it. So we actually often use from YouTube an aquarium scene. So it's like you're in an aquarium. And that patient, it was a major difference switching from an iPad, that patient was just lost in the aquarium, and really having that there as kind of a barrier to not look at the wounds unless she was ready was amazing. So we're very excited about this technology. And then further down the line, we're going to be using virtual reality goggles, this is the Oculus. This picture was from Stanford. It's not the Oculus Quest, but this headset is the Oculus Quest 2. The health lab, pediatric psychologist, multiple people from psychiatry department, but Wendy Cross is a pediatric psychologist also collaborating. So my point is that we'll be able to develop software that might be specifically tailored to different types of procedures and sedations. So we have the software engineers to write the software and behavioral specialists to help guide us. Something's going to happen, but not as painful. Like, would a butterfly land where you're defective, or should you just be completely out? And those are really fun things to think about. So just stay tuned for that when we figure that out. And that's it. So this is our contact information. You know, the URMC emails have an underscore, but it's not showing up here. And we'd be happy to help you at any time. Does anyone have any questions?
Kate, I see there was a question in the chat room from.
Would you guys mind if I just said something?
Oh yeah.
LJ?
I think I have to unshare, don't I? I don't know what's going on.
Yeah.
Would you guys mind if I just said something quickly?
No, go ahead, Pat.
So I want to thank Kate for really spearheading this. She's actually done an amazing job trying to bring a service in a coordinated way to do the best for our kids. And it's not been easy. We are working towards this every day. And we now have commitment from the hospital to continue to drive this forward. So one of the questions I saw was a really important one, is that what about our folks with IDD? Well, I could tell you we have really engaged across the spectrum of our enterprise, complex care, Kate's program, dentistry, many other folks. So we're all committed to doing this well. And one of the opportunities that we're really trying to look at is there a place we could have labs drawn on patients with IDD who are very needle phobic or scared, where we could do it in a setting with a very light sedation like nitrous, things like that, in a safe environment. And so we are working on that. A lot more to come, but I really appreciate everybody's involvement here. And I really appreciate, Kate, what you've done to really spearhead this effort. And it's a big change. It really is. It's actually really a big change. So thanks. And thanks to LJ, I mean, obviously, and everybody on the call. You guys are amazing, right? It's all about us. It's all about us making sure we take great care of our kids, all of them, and young adults. Oh yeah, and old adults like me.
Well, thank you for that. Yes, we really, it's really great to be able to offer those kids something. And, you know, we were finding many services had nowhere to go. In fact, even our epilepsy service had to select meds based on which ones, you know, they'd be able to get levels for. So I think we're really excited about pushing this forward. Thank you.
I'm just going to ask, can we share your slides with the team? Would that be okay? Because everybody kind of represents their practice, and so it might be nice for them to be able to take that information back and the contact information, and we can share that out later. Yeah. And if there are any other questions for Kate before we move on to our next topic? Questions, comments, you can pop them in the chat, or you can feel free to speak up. We're not as big a group as we are some nights, so feel free to speak.
I have a quick one. For procedures like a VCUG or an MRI, how do you logistically do that? Should we schedule with radiology first and then contact you if sedation needed, or does radiology initiate that if we think a patient needs sedation?
Yep, they will initiate it.
Okay.
Yeah, and we screen with them, so you don't have to worry about that. If there's something special, like the parent's reluctant to have it done because they're worried about sedation or something like that, feel free to contact us and we can try to help you with that. But for VCUGs, most of them are being done, well, either with no sedation or with oral midazolam. And then if we need to, we'll add that intranasal dex. Some centers do use nitrous for that, so we'll be curious to see how that works when we get it. For MRI right now, they get the techs and the nurses look at everything that's going on. They look at the patient chart. They look at the type of scan. You know, does it require contrast? Does it require breath holding? How long is it? And kind of make a judgment. If a child fits a certain category, they'll offer to come in to try without. And they've been successful with that. It's mostly like the 6-ish year age group because they have goggles there and lots of distraction techniques. And then now we're adding this other layer where we can offer the intranasal. So that's something, you know, I think sometimes people don't want to have the MRI because they don't want general anesthesia. This is something we can offer that's, you know, safer than that.
Great. Thank you so much.
Excellent. So again, Kate, thank you so much for being with us. Thank you for what you're doing. I know this is an incredibly valuable service for so many of our kids and families, and we appreciate you joining. I know you may not be able to stay on for the whole meeting. You're welcome to stay, but if you have to Zoom off, we totally understand that too. So that was great.
Thanks, Kate.
Yep, I have to get going, but great to see everybody. Thank you.
Thank you.
Okay, thanks.
Great job.
So here, a little wave from everybody. There we go. Okay. So I've got control of the agenda. I promise you're going to end on time, but I'm just going to, I hope nobody's checking the boxes on this. That's the one nice thing about everything going out by Zoom. You probably don't have a piece of paper in front of you. I'd like to spend the next 20 minutes to 25 minutes actually talking about the topic of the day, the hour, the week, the month, the year. Well, not a full year, but it feels like a full year. So I would like to spend some time talking about school reopening and really getting a chance to debrief and hear where you are now a week into this. And I'd like to frame the conversation a little bit. So if you give me a second, I'm just going to share my screen just so that we have sort of a space to share from. Did that share? No, that did not share. Okay, let's try that again. Okay, can you see that? I'm gonna just leave that on there, but I will encourage you, just glance at this. I'm gonna walk you through this because I want to be sure we're really hearing what's happening in the practices. So being mindful, we're really concerned about what you're seeing in terms of increase in volume, patient calls, parent calls, increase in acute visits that are related to the positive screens that are happening at home or at school for patients. What's happening with the COVID testing in terms of what you're either able to do in your office or referring out to urgent care. How long is it taking you to get COVID test results, and are you getting them readily? I hear from many of you that the patients are getting them first, at least in the URMC system out of my chart, and that there's a delay for you. How's the attestation document and that process that we outlined? We need feedback on that. We need feedback on the masking tolerance document. Want to hear if you have billing concerns. And in particular, would like to hear these last two things. Where are there departures from the guidance offered? Because we know there are departures. We know depending on what county you're in, there are departures. Depending on the school district, there are departures. But it'd be nice to have some example. And we're doing this not just to have a venting session or spinning the rant wheel, as I like to think of it. We want to take that information, compile it, process it, and use that for very targeted advocacy and to identify what additional supports are needed for your practitioners, your teams, your practices as a whole. So you don't have to follow that guideline exactly, but that's kind of the stuff that I'm interested in hearing about, that our whole team is interested. Renee's going to help with kind of documenting some things. And I would say, I'm going to stop sharing my screen because I think it's much better to see each other's faces, just so and I'm just going to say, unmute yourself and go, because it's much better to hear your voice than to look at it in the chat. Okay. I'm going to call on you if you don't go.
No, I mean,
oh, right.
We're definitely getting much busier now. I mean, we're getting phone calls like that, and parents are definitely saying, you know, I wouldn't be calling otherwise, but my child's a little cold, and I know that I'm supposed to call you, and we go through the whole spiel that most likely cold, but we have to test you anyway to get you back. We're applying the same scheme for schools, for daycares. So kids who have cold symptoms, we say you have to come in for a test. When the test comes back negative, you got to be symptom-free for 24 hours before heading back. And parents are understanding, but we're swamped. I mean, we're doing video in the morning to set them up, and then car visits, and we're doing from our office and send them out to U of R. And we're getting results back 48 hours, sometimes 24 hours. Occasionally a misplaced test that comes back 72, maybe a little bit longer, but we're usually getting them back pretty quickly. And then once we get it back, we're sending a template within a MedEnt that shows they were tested. We saw this date, tested this date, and then go back in 24 hours later, and we're sending it through the portal, or parents are come picking up, or mailing it, and that's working pretty well. So I think the system's okay. The errors we're finding, I had one nurse who is sending not only the child home with symptoms, but the siblings home as well. One time told them they have that sibling has to get tested as well. I promptly called the health department, and they were great. They actually called the nurse, and she stopped doing it the next day. So I think we just have to give feedback to the school nurses or the health department to help us, so that the nurses don't feel guilty coming on as well. I mean, it's from nothing in the beginning of COVID to being swamped now, and and being overwhelmed, and like I said, ready to retire any minute. So, but it's getting there, and hopefully in the next year will be much more quiet.
How about others? Thank you, Doug. Thank you for going first, and thank you for sharing that.
Hi, Gail Mosher, rural, where every school has like a different Chinese menu. We've got crowded schools going 5 days a week, and others going 2, but I've never had more parents be happy that their kids have allergies, because that seems to be the hope that if I write a letter, acknowledge the allergies, that they will not have to be tested. So they're doing high fives for allergies and asthma and anxiety with belly aches. But yeah, we're overwhelmed. Usually 48 to 72 hours. We seem to have dance steps down how to deal with it, but it's very difficult because we had opened afternoon to acutes during COVID, and we sat doing nothing. Then we started opening it up, and now we have no openings for anybody anymore. So we're just scurrying, trying to figure out where to do these non-sick kids that we have to treat as if they may have COVID. We have really no place to put them, and no hours or staff to handle it. But on we go. And I'm aging in dog years, I think, this year.
Oh my goodness, Gail. Okay. Thank you for sharing that. Who else?
This is Carolyn. I'm just going to second what Janet said. We have been using the AHP letter, and yes, I know that Monmouth County Health Department said symptoms improved, or no, asymptomatic for 24 hours. That's the letter we're using. I'm fine with that, and I assume that the families and the nurses are doing whatever they feel like, and it's more like if they're improving, they're probably going to go with it once the test is negative. But that's basically what Janet has written. We're just writing what you said to say, what the health department said to say, and presuming everybody else can figure it out amongst themselves.
I think that, Carolyn, I would agree with that. We went through this so many times. And so in part, our goal was to put that determination of asymptomatic on the family, on the parents, because they have to do it every day anyway. They have to attest to that thing if their kid's going into in-person school. And we didn't want it to be that second round of another call back to your office when I know you're already getting flooded with calls saying, I need the note now because now my kid is asymptomatic. So once you have the negative test, you should be able to give that to the family, and then they should make that determination. That is definitely very clearly what the New York State Department of Health guidelines stated. It is not supposed to be, not the same guidance as state ed or as Office of Child and Family Services as it is in the daycare setting, which is extraordinarily confusing, I should say. And I think I feel like I'm a broken record, and I like to think I'm an eternal optimist, although my optimism is starting to wane a little bit. We keep hearing, I'm seriously saying this, that the revised guidance is somewhere going through the state right now that would lighten some of that. But nobody can say where it is and why it hasn't come out. And we're hearing that from our colleagues at the County Department of Health, who really have become fantastic advocates. So I'm seeing a question in the chat from Leslie. If we are actually suspicious for COVID, what day of symptoms is the best day to test? You know, it's a great question. And I think there's not enough information to be able to definitively say. I know we remember, Chad, we sort of picked Brenda Tassini's brain about that a lot. And you're 5 days, are you saying, or 5 hours? No, I don't think we can say 5 days, but clearly, you know, Brenda was sort of saying, you know, it would be nice if it wasn't the first day of symptoms. You know, you have more likelihood of having a true positive test if they've been symptomatic for a little while.
Yeah, 5 days is where you get the highest sensitivity.
Right.
3 days, you're like 87, 89% of the way there. So, you know, I think 5 would be the best statistical, but reality sets in and people don't want to wait 24, much less 3. So I think, you know, getting in those 24 hours out is probably a minimum.
Yeah, that's where we have to be right now. And I guess, I mean, I think this is a bit of this is something in evolution. I think if we continue tracking our data at this point in time right now, I mean, Chad just updated on the call that there's been a few more positive cases. The things that are reported on the state website really were only 3 cases, I think, right? The 2 that you mentioned, Chad, in Fairport, and 1 that was an adolescent. There are some other positive cases reported, but that goes up to 19, so that could be some of the college students as well. The majority of what you're seeing back, I think, is negative at this point. And these kids, many of them are better even before they get to you, is what I'm hearing.
So I have a question about that. So we were talking about 2 options at our office, and one was if the family called in for an illness COVID appointment, would we see them, assess them, and have them come back for testing on day 3 or 4, versus they call and they wait until the symptoms have been there that many days to get assessed and tested? Just because it sounds like we're going in circles. If they're coming in on day 1 and then the tests are best.
I think there isn't a guideline on that. So this is going to be where it's your best clinical judgment. And I think you're going to get a lot of pressure from parents to have their child seen earlier than later because they want the test, because they want to get them screened and back to school. So I think, I think particularly if you are concerned about those symptoms potentially being COVID, because it sounds like most of the kids that are coming in, you guys are kind of like, we just have to do this. This is not what I would have thought would be something I would be concerned about. So if you're really hearing symptoms that are more suspicious for COVID, but a child who's not that sick, where they have to really come in and see you, you know, maybe even thinking about a televideo visit for assessment and then trying to postpone to wait a couple of days on the test. If you have a parent who, you know, who will go along with that. I think this is just it's so frustrating because this isn't even clinical judgment, right? This is sort of like you're juggling guidelines. I mean, it's death by guidelines. So Doug has asked in here, since there's a chance for false negatives, that's why the guidance says symptom-free. Yeah. So really, Doug, I think that's part of it. I think the other thing is they're trying to make guidance that is black and white, where there really isn't a lot of room for judgment, you know, not symptoms improving. What does that mean to someone? Just like done. And I don't know if that will specifically change or not. What are you hearing from parents?
Well, LJ, I can tell you that one of the things that we're dealing with, which I'm sure everybody is, but it's a simple thing, but parents are calling for the results. And they want the results like the morning after it was done, even though you say it's 48 hours. And then my staff is trying to accommodate them by calling around, and then we're trying to call everybody back. So usually with a strep, we just call positives, but we now are trying to call everybody that we get a test for, because we can't always assume that the urgent cares or anywhere else are going to be calling them. So with the phone is like crazy busy because parents are calling multiple times. We're trying to get them back. We don't get them. They, you know, and it just seems so silly, but it is just taking up inordinate amounts of time. You know, seeing kids, you can see them by, we start usually out with the video and then bring them in if we need to. And if we really want them tested, we just send them. We don't even see them in our office. We've only tested a handful because we don't have very many swabs. We're like hoarding our swabs. And but it's the results and trying to get them the results back. And people are calling it all hours. They're calling after hours. They're calling because they want to know what the test was. And that's the practical thing that is just burying us.
I understand that, and I've heard that from others. Does anybody have a system that's working for them that you want to share? Or are you all experiencing the same thing?
I think we're experiencing a very similar thing in our office about the results. Parents are really anxious about it, so they're constantly calling. And the results, we are sending them to the U of R, and they've been taking 48 to 72 hours, I find. The urgent cares were coming back in like 24 hours. So that's what I was expecting. But now we started sending them from our office, and it's a little bit longer.
So I'm hearing 48 for most. I heard a little 24 on a rare occasion, but 48 to 72 sounds like where we're at. Okay. I saw a couple of other things in the chat there. That many parents have not heard that a COVID test is required to go back to school. And so I think that something happened in all of this sort of release of information. For a while, the other schools were sort of sending out everything. I mean, you guys saw that, right? They were sending out what was going to happen, and we didn't even know what was going to happen from a healthcare standpoint or what we were supposed to be doing. And then everything sort of held. And then the County Department of Health did release that guidance to the school superintendents, the revised guidance that you all have at the same time. It was sent out at the same time, but I don't know that things have been shared as widely with families. And I can certainly think as a parent in a school district, I don't think that second round of guidance was ever shared. So one question I have for the group, it feels to me like this would be a really nice opportunity. Some of you are doing it individually, but to have some kind of a forum dialogue with our school nurses and incorporate some of our great, I mean, some of you are school physicians and in practice, but incorporate our school physicians and the school nurse to come, like have this kind of a dialogue, because it's just as stressful for the school nurses. And I do think that you know, they are looking for some more specific guidance as well. So I just was curious if you guys thought that could be helpful. Because if we were all kind of playing with the same rule book, at least, if we could have a little more consensus around, and I'm just going to say many of you have messaged me about kids who are anxious and who are having a stomachache at school, or who, you know, are complaining about a physical symptom, as we know, because they're stressed, and that completely resolves within hours. But then they're still having to go through the COVID testing. And I just wonder if we can help inform a little bit of the assessment around those kids too. So thoughts about that? What have you guys been seeing? And what do you think set something up with the school nurses?
I think that would be great to set something up with the school nurses. They play such a part in who ends up coming to our office that I feel like if we're all on the same page, it would be less frustration on our parts and probably a lot less frustration on their parts as well. That would be great.
Okay. I think that there's an opportunity to ask for that, because at this schools reopening task force, you know, the district superintendents are present there. And so, as well as the superintendents for the outlying, so not just Monroe County, but for the surrounding counties as well. And so I think that, I think we have an opportunity that has not been capitalized on yet. And they are not, the school nurses are not in those work groups or in that task force, which I think is something that I would be happy to bring back and sort of elevate that and see if we can get some connection. If we did something like that, would any of you be, like, you can stick in the chat, would you be interested in participating in that kind of conversation? You may just be tapped out and not able to, and we can, you know, try to do that with the county and with some representation from our group. But if you're interested in participating, just let me know. Because I think that that would be a really key thing to have in the next couple of weeks. Thanks, Carolyn. Thanks, Joanne. That's awesome.
I would be on board too. And I was just going to add that I think we need to educate our school nurses, because I think our teachers are not very educated on what are symptoms and what needs to go home. I had somebody who had such congestion and cold symptoms that she had to change her mask twice during class, and she still wasn't sent home, and or her parents still were not told to go see the pediatrician. So I sort of feel like that dissemination of information and the fact that there are guidelines out there needs to be better communicated.
Okay, thanks, Jen. Yeah, that's the opposite extreme, right? Like that's one that like that kid probably should get tested. Okay.
That's how I drive things at the Golisano. I want everybody working all the time, no matter what.
Thanks, Pat.
I just thought I'd add a little levity. You know, I know it's kind of crazy. So, you know,
Oh my God,
I think you're right. We just need to make sure we have some good communication strategies. And I think that continues to come up over and over again. So we will try and help out however we can.
Thanks, Pat. And I am seeing things that you guys put in the chat. I always have a hard time keeping up because I try to look at your faces while we're talking and then I can't read the chat. But I am seeing Lisa Smith's message about the school nurse in Pittsford and how they saw 26 kids on Monday, 1 for COVID symptoms and 25 for anxiety. You know, we're going to have some discussion around this. We're going to transition towards the end of the meeting and talking about social, emotional, and behavioral health for kids. And so I'm just going to put a pin in that, and Holly Brown, let you talk a little bit about that. So now Lisa's saying, can we request the superintendent distribute the materials? My understanding is those materials got distributed, but I don't know if I think they got distributed in the last few days. I don't think it happened prior to the kids coming in, but we will ask about that. And I think we can reinforce that. And I do think if we set up some kind of a meeting, we may need to do it. I don't know if we can do it where we get everybody involved, but maybe it's a sort of a quadrant kind of thing. So, you know, sort of Northeast quadrant schools, you know, Northwest quadrant schools, et cetera. We've got some nice collaboration now going on with the city school district for those of you who care for kids in the city schools. And if any of you who care for a number of kids from the city schools are available and interested in participating in some really cool collaborative work there, trying to get them back to in-person school, we would welcome that. Mary Beth, I think you're going to speak.
Yeah, can I ask that question? What are we doing to get those most needy kids in the city back in school? You know, we have a large population. It is breaking our heart that every other school in the entire county is open, and we're just watching those kids flounder. I feel like we as a community owe it to be involved in that conversation and to really advocate strongly that those kids go back to school.
So I always love when you talk, Mary Beth, because like you have so much passion and you are so right. So I want you to know that those kinds of conversations have been happening from the moment that the announcement came out that they were not going back to in-person school. And I'm going to give Pat Brophy a ton of credit. Jill Halterman actually has been really championing this. My husband Jeff and I are working too. But we were able to, one of the ways we were able to make connection just in this last week has been through Rock the Future, which I think you guys know is sort of the supportive organization working with Rochester City School District and collaborating with community-based organizations and with parents. And Rock the Future has a convener group that met today. And we were able to zoom in a number of practitioners, both pediatricians, nurse practitioners, family physicians, behavioral health providers like Holly Brown was on that call today. And we had a conversation about like what we saw as the 3 key priority areas that we wanted to help in, we were ready to help in. And so this is what I'm saying, like, I want you guys to put your names in the chat. If you have a significant number of RCSD kids, please put your name in the chat. I would like to get you engaged. This was just a conversation, but the superintendent, Dr. Leslie Small-Myers, was there. She heard that the pediatric and family medicine community is committed to and able to support that return to school, in addition to supporting social and emotional well-being for kids, whether they're virtual or in school. And also this full court press everybody's doing right now to try to get the kids who are behind in their immunizations and well care visits in this next 14 days, because those kids, you know, ultimately will get bumped out of virtual school, which is crazy to me. But they will if we can't get those kids taken care of. And we're trying to make sure that that connection happens with the medical home. But you are right, it is just that much more disparity that is, it's just unconscionable. And I'm not criticizing them for their decision, because I don't think they have felt like this for them was sort of the first, like, oh my God, like you guys would come to meetings, you would talk to our teachers, you would meet with the principals, you would help us, you know, assess these kids and test if they need to. You know, there's so many worries about this testing requirement and this assessment requirement for kids who may have transportation difficulties. So we brainstormed a whole bunch of things, like working with the school nurses in the city school district to then have kids be able to be actually COVID tested there, but do an assessment via televideo, initial assessment for triaging with their primary care provider, not someone else. And then, you know, be able to figure out, does that kid need to come to your office, or can you institute a care plan, which means that they're on the track to being able to come back again. So we laid out like a lot of different things, and Holly, you should pipe in. It was it was an hour-and-a-half meeting. It was so positive by the end, right? Go ahead, Holly.
I was just gonna say, I mean, there was real, true, genuine appreciation for the opportunity to collaborate. And there's a lot of just the motivation to do the work. I think one of the things that was raised, as would come as no surprise, and it's an important piece, is related to making sure that whatever interventions we think about and craft, that they are specifically and precisely designed for individuals of color, Black and brown people. And that was a sentiment, I think, that was echoed throughout the entire crowd. And we got some specific questions about that. And I think there's a lot to think about, and there's work to be done. So it was great. It was a great conversation.
I mean, I think, Mary Beth, you know, my dream in this would be through this crisis, we actually develop something that's like far superior, integrated, whole health for kids, social emotional supports, and their education is improved. We get them back to in-person school in a way that is transformative, as opposed to everybody throwing up their hands in a crisis. And again, these kids get more hits than they should ever have. So I'm seeing different ones of you in the chat posting. You've got lots of RCSD kids. I know that you guys do. Thank you for being willing to participate. And I mean, I had figured I was going to reach out to you individually, but it was a great opportunity to talk about it on this call. Yeah.
One aside. So there's the whole health evaluation and that whole angle of it. But I'm hearing already, and they only started school Monday, I'm already hearing from a lot of parents that they've thrown up their hands, that the families are saying, I just can't do it. I'm not home. I've got 5 other kids, you know, that kind of thing. And I'm wondering, is there anywhere we can call that those kids can get some extra help? You know, like, not like a truant officer, but they basically are truant. And if they were truant, somebody would get them into school. When they're home, not on Zoom, and the mom isn't able to do things with them. I had a family in my office today, they don't speak English. And so they can't help. Is there anywhere we can call where those people could get assistance?
So I don't know if I have a specific answer, but I have a couple of thoughts. So one is this: we can bring this question directly to the Rock the Future team, because this is a lot of what they are about. Is it, you know, it's ensuring educational success for kids. And so because they partner with so many different community-based organizations, and it isn't just us in pediatrics and in primary care who are concerned, all of these other community-based organizations who work with kids and families to support them are are very distressed and concerned. And I think from the very littlest, the little ones, you know, I can't imagine a 3-year-old doing preschool by Zoom, to our, you know, 12th graders. So I think Rock the Future is the place to bring that question, because I think that they think out of the box of supports. I do know that a number of the schools have done, you know, it's just not consistent across all the RCSD schools, but some of them really have put in place follow-up and supports and connection for their kids, but I just don't know that it's consistent. So I think if you have a patient that you're worried about with that, let me find out who would be the right person, and I can send that back out to all of you. And I think we begin making those connections. You know, we need to do something on a system level, but we can also advocate one child at a time to try to get them some help. So we'd be happy to do that. Great. And I think there's a lot of suggestions we can put in the chat about Boys and Girls Clubs, or is at the Museum of Science, I think. And I think that, there's the Center for Youth. There's any number of other resources. Hillside is doing a certain level of supports for kids. So I think we just need to make sure that they're getting coordinated and in the right way. And I think, I pray that this is only a 10-week pause. I mean, it's not a pause, but I hope it's only a 10-week remote learning for these kids. I know that the superintendent felt different. You could tell she felt different from the beginning of the call to the conversation was happening at the end of the call. There was much more hope and energy and like potential that we might be able to do that. So I think it'll be all hands on deck, and I will definitely tap all of you or whoever of you are willing to participate, because I think that was one of the most powerful things to be able to say, you know, every single pediatrician and family physician in the community who sees kids in your district is fully supportive of helping. And I think that they were kind of blown away by that. So thank you.
Hey, one more question for the
group.
Yeah. Has anybody looked into the Abbott or Cepheid point of care PCR testing system? We've been, you know, talking to McKesson about it a lot, and I just wondered if anybody, you know, the Cepheid is a 40-minute test, the Abbott is a 10-minute test, but I don't know if anybody else has had any experience with that. It's PCR, so it would be acceptable.
So we have, can you hear me?
Yes.
It's Teresa Almy Albert from English Road Pediatrics. So we've had Cepheid for a while for flu, RSV, and strep, and then the flu RSV combo. So we've been waiting forever and ever for the Cepheid COVID. But what we were told is that they are working on a COVID, flu, RSV cartridge. So you would do it all in one, and they're phasing out the regular just COVID. So again, we're waiting and waiting and waiting. We've been on the list for months and months to kind of get that because we've had the equipment for a long time, but they're going to wait until they have that perfected before we can get it. So it's kind of a bummer. And then we're still not sure if
oh, did we just lose her?
I don't think Cepheid has FDA approval yet.
So we know a couple things. Yeah, so we know a couple things on this, and Chad, feel free to jump in because we have looked at this extensively, and URMC has been looking at this extensively. Cepheid does have a non-PCR platform that we are not recommending because of the whole issue about the antigen testing and not performing to the same level of sensitivity. The PCR platform, what was noted appropriately in the chat is that acute kids does have the Cepheid analyzer, but they have not gotten any reagent. So this is the thing about, you know, you kind of get just so much reagent coming to your community based on need. And so while I think our URMC labs, RH labs, our community would support, you know, the Cepheid PCR, you have to demonstrate a certain level of, like, you have to show that you've been doing lots of tests to get that, is our understanding from the acute kids folks. But they still don't have reagent. They've had a machine for 2 weeks now, 3 weeks, I think, and they still don't have any reagent to be able to run tests.
I would also say, oh, sorry.
What's that, Chad? Go ahead.
So when we've looked at it, and this has been as recently as maybe a week, 10 days ago, the Cepheid, to even get in the allocation pool, you had to sign a contract for a guarantee of at least performing 600 tests a year, I think was about the break minimum. And it just wasn't feasible for most practices to do that volume. The cost of that was almost prohibitive. Abbott, I think, is a little bit better, but their volume of distribution has not been as good because Abbott has several different platforms. And my understanding is it's the same reagent that works across all the different platforms. And so the large labs are gobbling up that reagent pretty quickly.
And I think, the same thing, I know you talked about the Abbott platform, and people have called and have messaged us about the molecular testing capacity on Abbott, but it's the same thing. It is not showing that same performance in the field. So it's really frustrating because I know how great it would be if you could just do this in your office. But at this point, with the level of infection rates that we have and knowing what we're seeing already now, how many of these kids are negative, you're going to be double swabbing. I can't even imagine, doing it again on a kid once you've got a negative test and then going back in for the next one. So I think at this point, it's not an option. I mean, I give credit to Brenda Tassini from Infection Prevention and our URMC people. They keep going back. They keep looking at this. Like if there's movement, if there's better performance, if there's something else we can do, we will definitely, push for that. I did see a question recurrently in the chat from Eric Ingarowski, wondering about how people are billing for this. And I wanted to make sure that that answer came through. And Eric, do you want to speak up? Are you talking about billing for testing specifically? Can he speak up?
Hi, LJ, sorry.
That's
no,
okay.
Mainly talking about billing, whether you go under a symptom code for diagnosis or attaching a Z code. So at least what we've been told is if we bill under just symptom code, it's likely to go against patient deductible or cost share. And if we attach a Z code, then it may be covered completely as it's a COVID-related illness, and therefore there's no cost share to the patient. Our concern is that all of these Z codes has been exposed to a patient with COVID or suspected COVID exposure, but those really aren't true in most of these kids, meaning I suppose we can hypothesize anyone could be exposed, but a lot of these kids, have a runny nose and where they have no true exposure that's known. So the question is, how do we ethically bill and what's the standard within our community for that?
So I'm going to let people answer what they're doing before I make a comment. Anybody want to share their billing practice?
This is Carolyn. We're probably doing it all wrong. I mean, we've just, like URI, whatever the diagnosis is, and I get what Eric's point is, which we hadn't taken into consideration. I think some of the no copays related to COVID have actually gone away, so it may not be as much of an issue right now, but I get what Eric's saying, and we're probably doing it wrong.
Has anybody been using the Z codes?
We have. It's Dave. We've been, and actually my kids need to be tested, and at one point about 6 weeks ago, and one of the actually my wife and I also got tested, and two of the providers used the Z code and one didn't. We got the bill for the one that did not use the Z code. I think it's a pandemic, so technically, as you said, Eric, everyone is technically exposed. So we haven't run into any issues when we've been using the Z20.828 code. There's also another one, I think it's a Z30, which is a rule out code for respiratory infection or illness. But I think with that one, you probably have to wait until you get the result back as a negative. So it just kind of might delay your documentation or your coding, but we haven't seen any issues with the Z20.828, adding that to the symptoms that the patients are complaining about.
The reason I brought this whole issue up is that we've had a number of kids that had actually testing for colleges that went to urgent cares and they were billed under Z codes, which means the insurance actually covered it. And we had told them that they would not be covered other than if they went to a free state site, because insurances don't cover just screening for going to college, etc. But it seems like some of the urgent cares have been billing in a different way, so it was covered, and we're like, gosh, that really first makes us look bad that we're giving them information that's not true, but in reality, it's the urgent cares that I don't think are billing on the technical level there. I think it's different when patients have symptoms, so I could sort of see using a Z code or not, but we've seen it used in tons of different settings that have been a little concerning.
Thanks, Eric. My eyes are boring into Chad's screen right now, but he doesn't know it because he can't tell. But I'm going to just put myself out there and I'd say I'd use the Z code, right? Yeah, I thought you would say that.
Every time we've talked to any payer, the Z20.828 has always been the default answer, and it's always been the, you know, as long as there's going to be parity and coverage of COVID-19 encounters, the Z code is always the default. Don't use the U07.1, which is COVID-19 suspected or whatever it is. It's the Z20.828 that's the go-to. So I think everything you guys are saying is exactly what I would do. And, you know, every time we've asked, it's, you know, there should be parity, there should be coverage at least to the end of the state of emergency, or probably at least through the end of the year. I haven't heard any whimper of that going away anytime soon, so I would stick with the C20.
Yeah. So if you haven't been, I think you should start. And we can like when we send out the slides and we send out sort of a little synopsis from this meeting, we'll just put that code in there as a reminder so you can share with your colleagues. I would do it. I think absolutely. All right. Anything else that's pressing on COVID? Because what I would love to do is in our 20 minutes, 15 minutes remaining, I want to give Renee a moment to just sort of do a gain share update. And I want to give Holly Brown a little bit of time just to talk about the depression screening and behavioral health stuff before we wrap up. I know on the agenda I had myocarditis in kids, but I actually am thrilled we ran out of time because we really need another couple of days on this. We are working with Peds Cardiology to develop an algorithm around this that's very clear cut so that people know, and it's not done yet. So I was hoping I wasn't going to have to just sort of tap dance that one, and I don't have to. So, so I'm thinking, Renee, do you want to just do the gain share update, and then we'll let Holly.
I would say let Holly go first. I think Holly's content is more important, and whatever's left over for me, I will manage to get the gain sharing update. And everyone's got their money already, so they're probably not even interested in hearing about it. So.
Okay, sweet. Thanks.
Let me unmute. Renee, I appreciate that. I had a couple siblings, so I know how to share. So I'm gonna aim to do that. And Elizabeth may join me a little bit in this conversation. Can you see my screen okay? Yes? Okay, terrific. So I wanted to talk with you all about a couple of things tonight. Just go over, dust off and remind you about the Universal Screening Initiative, depression screening and response, go over that quickly. Remind you about the AHP resources that we have underway, available to you right now, and some of the changes there. Talk about our trauma-informed care initiative. And I have an idea to ponder, but I'm willing to punt that so Renee can get a few minutes at the end of the agenda, and we can pick that up next time. So Elizabeth, feel free to unmute and jump in at any point. But remember, we have our depression screening and response initiative underway. We had intended to be talking more about this, and then that pandemic hit, right? And so a reminder about the goal of the initiative is to increase universal screening for depression and provide options for age-appropriate follow-up for patients 12 and over in the primary care setting. Our goal is really to look at a 15% increase in screening rates annually. And eventually we're looking to move to the quality measure, and now that's Elizabeth's lane for sure, of depression screening and follow-up. So Elizabeth, do you want to say a couple words?
I was just going to say, yeah, I know, I think Holly did a nice job of teeing this up. We know that everybody has unique challenges in their patient populations under the best of times. And especially this year, things are sort of different than we had anticipated. So Holly and LJ and I are happy to come out and meet with any of you individually. We've actually had a couple of meetings with some of our pediatric offices, and they've been really wonderful to get to talk to practices about what they're doing and how. So if that's something that your practice can accommodate right now, if you have the bandwidth and the desire, we're more than happy to come out and talk through what we're looking for, make sure that the data is right, and see if there's any clinical support that we can offer as well.
Yeah, and come out is virtually, right?
Oh yeah, we're Zooming. It's just old habits die hard, guys. It's nice to see your faces, but we're not actually going to drive to your offices these days.
Yeah. So just a reminder about the depression screening, and to that point, the reminder that we have the toolkit available to you on the AHP website. That's the link to the website. If you need a reminder on that. Just to recall that the website or the toolkit offers information about how to screen, how to interpret, how to think about response to screening, the resources that are available to you, such as you have a youth who's acutely suicidal or has suicidal ideation and how to manage that. Reminders about medication, a really nice medication sort of algorithm, if you will, to think through, and some side effects to be mindful of. That's just to name a few. That's not an inclusive, comprehensive description of the toolkit, but sort of the highlights. I also wanted to remind folks that we have had a shift in our behavioral health integration office hours, as Dr. Nazra likes to call them, or our huddles. We were doing them at the beginning of COVID, through COVID, on Tuesday and Thursday from 7:30 to 8 a.m. We have shifted this week was our second week of this shift, to every Tuesday from 12:15 to 1. And again, this is designed to provide just-in-time consultation for you as a provider, along with the care managers. We, as anybody has participated on the huddles, we talk about all things from soup to nuts, right? From, diagnostics to medication to system management to transitions of care. We have, it spans, the age span. And has been really rich, I think, and useful. Some of the things that have been born out of those huddles is, we have followed up afterwards with providers if there was needed for ongoing technical assistance related to the case that was presented. So we are here for you and certainly available. And then the other thing that I just want to remind you of is that if you need an individual consult, you can reach us via the email address listed here on the slide. Of course, you want to tag CC your care manager in that, because our work is in consultation with the PEDS care management team. Anybody want to say anything else about the resources? Nope. Okay. And then finally, I wanted to let you guys know about our trauma-informed initiative. This has been really quite cool from the standpoint, we didn't know how important it was going to be when we started talking about this at the end of January, beginning of February. We knew it was important, but the salience of it as a result of COVID, we can't say the timing was exactly right to introduce this topic. So in the middle of August, we had Dr. Andrea Garraway give a talk at our AHP URMC Care Management Organization Clinical Grand Rounds on trauma-informed care. It was well attended and really fruitful information. And so as part of the follow-up to the Grand Rounds, we have devised, the BHI team has devised a training series on trauma-informed care that's focused on reflective practice and skill building. So the PEDS care managers, for instance, all the care managers, but the PEDS group is relevant to you all, are involved in this series. We're meeting for 4 75-minute sessions with our aim of skill of our care managers, which we know they do already. We're just adding some finesse to that, right? To skillfully engage patients and others using trauma-informed principles on interviewing in the settings of healthcare behaviors. We are doing some skill building around reflective practice, using scenario-based cases to teach and develop some trauma-informed skills, and really looking for development around curiosity, empathy, and non-judgmental presence in those scenarios in terms of their interactions. We're doing this in large groups and small groups. This is facilitated by the BHI team, and so care managers are also getting some coaching and feedback related to this work. So we're very excited about it. And I think you will see some of that pushing into the work that the practices are, that the care managers are doing at your practice. And if you have questions or interest, just let me know. I'll be happy to talk more with you about that. I think that's it for me, LJ.
Thank you so much, Holly. Questions for Holly? I saw a couple in the chat, but I think they got answered.
Thank you.
All right, awesome. Renee, you're up.